I want to take a moment to acknowledge the content in today's webinar regarding cultural sensitive care, assessment, and understanding another person's values, beliefs, and wishes are sensitive topics. We want to recognize that we bring to you our knowledge and experience, but understand that it is our duty and responsibility to our communities to continue the lifelong journey of learning to better serve those in our care. Just going to take a moment to introduce myself. My name is Brooke, and I'm a long-term care best practice coordinator with the RNAO. I will be facilitating today's presentation with Jen Bahoon, who is also one of my colleagues with the RNAO as a long-term care best practice coordinator. I just want to review the objectives of today's webinar. We are looking to broaden your understanding of the RNAO's long-term care best practices program and what it has to offer you in your long-term care home. We will give you a very brief introduction to RNAO's best practice guideline, a palliative approach to care, and we will review a comprehensive resident case study utilizing the knowledge and experience of our interprofessional panel members. In closing, we'll discuss next steps for you and your teams to ensure that you're fostering a culture that supports and encourages a palliative approach to care. Let's start by having everyone introduce themselves and their teams in the chat box. We would love to hear who is joining today, your roles, and what long-term care home you support and how many beds your home has. Welcome, everybody. We're so glad that you're here today.
Can I start? Hello?
Hi, yeah, go ahead.
So my name is Rita Thomas. I don't know if you see me. I gave you the okay. So my name is Rita Thomas. I'm a nurse practitioner in transitional care unit at Freeport Hospital in Kitchener. And together with my colleague Kelly, we have a little bit over 60 beds that we take care of. Our population is mostly old adult. And we really, so palliative has a role in a plan of care for our population here.
Great, thank you so much for joining.
Yes, thank you so much for organizing this.
All right, I'm going to take a moment to just talk to you briefly about the Long-Term Care Best Practices Program. Our program is funded by the Ministry of Health and Long-Term Care, which means it's a free resource to you and your long-term care home. The goal of this program is to support long-term care homes in adapting evidence-based practices that support systematic and approaches to providing quality care for residents. All long-term care homes in Ontario are encouraged to get involved. The benefits of this program include capacity for knowledge transfer, improving quality of care and resident outcomes, support for leaders, nurses, and staff in long-term care homes in implementing best practice guidelines, and improved quality of work life. RNAO's team of long-term care best practice coordinators promote and support the use of evidence-based practices. They work in consultation with long-term care homes and their interprofessional teams to identify practice gaps, develop action plans, and make and sustain practice improvements. Our team consists of 13 best practice coordinators who work within distinct regions across the province. If you're unsure which coordinator serves your region, please reach out to the RNAO Home Office or email us at ltcbpp@rnao.ca to get connected. A palliative approach to care in the last 12 months is a best practice guideline which provides evidence-based recommendations to nurses and the interprofessional team who support adults experiencing the last 12 months of a progressive life-limiting illness, their families, and their caregivers. The goal within the recommendations are to improve the delivery of psychosocial, spiritual, and culturally safe care, enhance the coordination of this care, and facilitate supportive work environments. This best practice guideline is applicable to all practice settings where a person and family require palliative care and end-of-life services. Now, without further ado, I'm going to allow Jen to take over the facilitation of our resident case study and panel discussion.
Thanks, Brittany. So good afternoon, everyone. I now have the pleasure of guiding a panel discussion where we're going to follow a resident through their journey of long-term care, highlighting the importance of collaboration, assessing the resident's individual needs, and reviewing the resources available to assist long-term care homes in providing a holistic approach to care. So joining us for our discussion today, we have our very own Janice Britton, who is a results-focused leader, bringing her experience in long-term care, leadership, performance improvement, policy, government relations, and regulatory compliance to her role as an RNAO long-term care best practice coordinator. Next up, we have Mahogany Hines, who is an active and ardent member of the palliative care community. She currently volunteers her time to act as the RNAO Policy and Political Action E&O for the Palliative Care Nurses Interest Group and is also acting as the interim president. Mahogany works as a registered nurse full-time as a palliative pain and symptom management consultant through the Niagara region. We also have Tamara Johnson, who is the Director of Programs and Community Services at St. Josephsville and Dundas. As an RN, Tamara has worked in multiple settings over the course of her career, however most of her journey has been in long-term care. Tamara is also the Director of Operations for the HNHB BSO program, who is currently in its third year of their journey to become a BPSO with RNAO. We also have Judy Harvey joining us, who's a registered nurse of 30 years and is the hospice bed coordinator at the Nipigon District Memorial Hospital. Judy completed an advanced clinical practice fellowship in 2019 that was supported both by the hospital and NRAO. Her current research is driven by her passion for end-of-life care and the traditional Indigenous cultures of Northern Ontario. Judy serves on the board of directors for Hospice Northwest as the regional representative, as well as many other palliative-focused committees. So a big welcome to all of our panelists, and thank you so much for taking the time to be with us today. And now, while we have a group of professionals to guide our conversations, we are also wanting this webinar to be really interactive. So I'll be posing questions to the group throughout, really to promote discussion and the sharing of ideas. So I now have the pleasure of introducing you to Bob. Bob is moving into your long-term care home today. So let's get to know him a little bit better. So Bob is an 85-year-old male, currently a full code with a palliative performance scale of 60%. Bob has 2 children, one son named John and one daughter named Susie. Both children live in town and are actively involved in Bob's life. Susie is present for the admission, and she has been appointed by Bob to be his power of attorney for personal care. Bob lives with Alzheimer's dementia, congestive heart failure, chronic obstructive pulmonary disease, mild depression, and arthritis. Bob appears to be short of breath on movement and exertion, alert times 2, occasionally forgets year and month. Bob loves animals and has a pet cat, Jim, who now is going to be living with his daughter, Susie. So in the past 6 months, Bob has been admitted to hospital 3 times and was recently discharged home to his and his deceased wife's home. His wife, Margaret, died about a year ago. Prior to moving into long-term care, Bob had home and community care services involved and was supposed to be getting assistance from both PSWs daily and nursing weekly. But due to shortages in the community supports, this was limited. So Bob and his family made the decision to transition to long-term care from his home due to his increased needs for support and the decreased supports available in the community. Behavioural Supports Ontario has recently been involved as well as Bob's care. He started to show some repetitive behaviours and calls out for his deceased wife during the mornings. The BSO team will be assisting Bob with his transition into long-term care. Bob's spiritual and religious beliefs are unknown at this time. So Tamara, let's start the conversation off with you, since the BSO team already knows Bob and is involved in his care and the transition. Can you begin by explaining the BSO role and the supports available to residents living in long-term care?
Great. Thank you, Jennifer, and good afternoon, everyone. I'm hoping I'm coming through not too choppy. So for our particular region for HNHB, I just want to say that in other areas, the program may operate differently or the services may be initiated differently, but I'll speak to our area. So we have Behavioural Supports Ontario teams that work in the community, in our hospital, and our long-term care homes. So with Bob, we would be looking for a connection in that transition across the spectrum. So we would be reaching out to our BSO community outreach team, looking at what they had done with Bob in the home, working with him and his family to develop strategies to help him, with his grief and loss, and calling for his wife, working with his pet, things that settled and comforted him. And we would translate those practices, those strategies into the long-term care home. So our team will be receiving this referral either from our home and community partners or from the home directly for transitional support to Bob. So what that would look at is we would have a team, so perhaps an RPN and a PSW, or a social service worker and a PSW. And we also have mobile social workers in our program come and wrap that strategy around Bob. So we would get Bob's history from him, particularly because he's capable, and his family, and look at finding the meaning behind the behavior. So what works for Bob, what doesn't work for Bob? What is his interest? What was his past occupation, travel, all those things. So we get to know Bob as a person. It's very important to us to have that person and family-centered approach, and the tools that we use help us to delve into that. So we would complete what we call an I am who I am, which is a getting to know you piece with Bob. We would be looking at adapting his environment, setting things in their cues, things to help settle him and comfort him and make it look like home. We would meet and huddle with the staff in the long-term care home and share all those findings with them about Bob and his characters, his likes, his dislikes, and preferences, and help to identify what are those triggers for Bob to start looking for his wife or worrying about his pet, and how we can mitigate those triggers and put strategies in place to be more comforting to him. We had also worked with the team in-house and see what's working, not working for them. Our job is to model and coach these strategies so that we are doing a peer support to the staff in the long-term care home and better wrap services around Bob. Sometimes we make referrals to other partners in the community depending on the presentation we're seeing or our scope of practice. So we might refer to our partners in the Alzheimer's Society, our psychogeriatric resource consultants, our specialized team for geriatric services, or seniors mental health, all to support Bob. Work with the team, work with other partners in the community that perhaps helped them before, whether that was spiritual, cultural as well. So whatever we could do to connect Bob, Jennifer, and support the team with that transition is our role. And we would typically follow that for 6 weeks to make sure that he is settled into the home. And if he continued to need support after 6 weeks, we would move to what we call an episodic referral, spending more time with him specifically and adapting our strategies and moving forward with the team.
Excellent. Thank you so much. So Mahogany, many of the things Tamara was referring to surrounding Bob's values and beliefs really highlight the importance of advanced care planning discussions. Can you touch on this topic and why early identification is so important and what all is involved?
Absolutely. Thank you so much, Jennifer. So advanced care planning is so important, and thank you for making space for this dialogue. So advanced care planning needs to happen in advance for it to be advanced care planning. The earlier, the better, ideally before coming into long-term care, but it can start and continue at admission. It is easier to have these often difficult discussions early while residents are still able to discuss their values, wishes, and beliefs. It helps your loved ones and the substitute decision makers know how to advocate and honor your values, wishes, and beliefs. And it can also take the onus off the substitute decision makers in making what often feels like an impossible decision should crisis occur. Early identification grants opportunities to make informed decisions and plans. It potentiates early discussions that can be helpful to elicit thoughts and participation in treatment decisions and choices, including those for end-of-life care. Early ID can also help to establish a baseline for the person, as well as the family, as well as the care team. So some ways to begin early identification include identifying general indicators of decline, like advancing disease, which we know Bob has. Decreased responses to treatments and interventions, general physical decline, repeated unplanned crisis or hospital visits, diagnoses with high risk of hospitalization, things like sepsis, pneumonia, UTIs, dyspnea, abdominal disorders, even constipation. COPD and CHF which our friend Bob also has, are two of the diagnoses with the highest indicators of morbidity and mortality. And sentinel events such as serious falls or rapid weight loss greater than 10% in the past 6 months are all general indicators that we look for early identification. So why is this so important? It helps to get a basic understanding of the residents as well as the family's understanding of the illness and prognosis, as well as granting us insight into where they are. Residents are more likely to receive a palliative approach to care earlier, and this is associated with a better quality of life as people transition through their illness experience. Many residents are also less likely to meet the DSM-5 criteria for mental disorder or to report feeling more depressed, sad, terrified, or worried when they have early identification done. For families and for loved ones, early ID can relieve fear and help to realign the focus on what is important. It also takes away some of the difficulty of making those decisions because they know what their loved one would want. Many families often express gratitude for an opportunity to talk of death. It also decreases perceptions that the healthcare team is uncomfortable talking about death. By doing early identification, we can open dialogues and enhance the therapeutic relationship with those in our care all around.
Excellent. Thank you so much. So Jan, Tamara and Mahogany's responses really focus on the importance of an interprofessional approach to providing person-centered care. How does this align with the palliative care guideline?
Thanks, Jen. Well, to add to what both Tamara and Mahogany have shared with us today, I think the main concept that we are all trying to emphasize today is the fact that in palliative and end-of-life care, the person and the family must be included as key members of the interprofessional health team. Clear and ongoing communication promotes a mutual understanding of the person's goals of care and avoids potential distress resulting from persons and families having to repeat information to multiple interprofessional health team members. As both Tamara and Mahogany stated previously, early referral and early conversations with residents and their families is very important. Allowing them to gain understanding of the residents' wishes for advanced care planning, their goals of care, and also healthcare consent as it relates to the diagnosis and prognosis. Completing the palliative performance scale on admission and with care plan reviews allows for early identification and referral. Discussing the palliative performance scale with families as appropriate can improve understanding of what is ahead, help the substitute decision maker to make difficult end-of-life decisions when that time comes, and gives them a guide as to what to expect. Early discussions with families regarding clinical indicators of decline and end-of-life trajectories, wishes for resuscitation, or alternatively, a do not resuscitate order, can help reduce emergency room visits and greatly improve the quality of end-of-life care provided to the resident and the family in your long-term care home.
Excellent. Thank you so much, everyone. So my next question is for all the homes on the call. How do you communicate to interprofessional team members about discussions with residents and families regarding advanced care planning, goals of care, and healthcare consent outcomes? So feel free to either unmute yourself or raise your hand, or you can type any thoughts or ideas into the chat box.
So NAVFIT has said phone calls, work email, progress notes, care planning, care conferences.
Excellent.
Unit meetings, progress notes, and emails, Christina has said.
It's really good. It's good to see that, you know, there's a variety. It's not just one way of communicating. We know that that's really important to share in a variety of ways with your team.
Yeah, and someone wrote, unfortunately, from what I've heard, it's only through care plan meetings or conferences. And one home has created a palliative plan of care guide that is accessed by all team members.
Oh, amazing.
Go ahead.
All right, well, thank you so much for your contributions to the discussion. Okay, so Bob has now been with us for 6 weeks. The team has been seeing mild changes in Bob's symptoms and decline. He's starting to have more shortness of breath on exertion and intermittently at rest. He requires more assistance getting up from his chair, both in the dining room and in his bedroom. He now utilizes his walker for assistance, and his palliative performance scale is currently 50%, showing signs of decline to 40%. The nurse leading the care conference identifies that the home's philosophy of care is the palliative care approach. Upon hearing palliative care, Susie and John look at each other and become concerned. Susie asks why he has to receive palliative care, as he, quote unquote, is not that bad yet. Mahogany, I'd like to pass it over to you so that you can help us understand what the home means by a palliative approach to care.
Thanks so much, Jennifer. So I think the first thing that's really important for us to really outline, and if you take nothing else away from me today, hopefully you will take this, that people are not palliative. People are people first, foremost, always, period, full stop. Palliative care is the approach to care. It's a philosophy of care. Much like people are not to be identified by their diagnosis, they're not to be identified by the care in which they are to receive. So that's a really important critical component of the palliative care approach. Is people being deemed palliative is actually not true because they're not identified by the care process. So a palliative care approach is a multidisciplinary approach. It's an interprofessional approach. Ideally, it should begin at the time of diagnosis or the presentation of symptoms, as early as possible in the diagnosis trajectory when we talk about life-limiting progressive illness. It also addresses physical, psychological, social, spiritual, and practical issues, as well as their associated expectations, needs, hopes, and fears. So it's multifactorial, and it addresses people as whole people, not just as one ideology. So they're not just physical. We don't just exist in a physical domain. It also strives to help patients and families, and it's really important to identify that families means whoever their chosen family is or their given family, and this can be identified by the person, to cope with loss and grief. And remembering that loss and grief don't just happen when somebody dies. They happen much, much, much earlier, and every time we experience loss, we experience an associated grief accordingly. It also helps to treat all active issues and prevent any new issues from occurring. So just because somebody has a do not resuscitate does not mean do not receive care. It's really important that we address that, and that it just means personalized, person-centered care that includes their family as well. And it promotes opportunities for meaningful and valuable experiences, as well as personal and spiritual growth and self-actualization. One of the things I often say is you're not dead until you're dead. We often treat people like they're already gone much, much too soon. And it's really important that we give people opportunities to talk about the things that are meaningful and valuable to them throughout their lifetime. So that way they live well until death, and we can support their families as well, because part of that person's comfort comes from knowing that their loved ones are going to be okay after they're gone. So it's appropriate for any patient and or family living with or at risk of developing a life-threatening illness due to any diagnosis with any prognosis, regardless of age, at any time, that they have unmet expectations and or needs or are prepared to accept care. So these definitions come from the Fundamentals of Hospice Palliative Care, which is a course that many PPSMCs provide across the province. And we will give you more information about the PPSMC role coming up.
Perfect. So that actually goes right into my next question. So as a palliative pain and symptom management consultant, what exactly does your role entail, and how are you able to support homes with this approach to care?
Thank you. So as we keep referring to them, so a PPSMC is a palliative pain and symptom management consultant. So just so you know that PPSMC role, that's what we're referring to. So PPSMCs are registered nurses who have specialization in hospice palliative care. PPSMCs are a free resource for all long-term care homes across the province. So whether or not you're aware of it, you probably have a PPSMC that you can reach out to support your staff. So All of our roles look a little bit different, and for the purpose of today, I will speak to my role more specifically, but many PPSMCs do consultation in various forms, either via phone, virtual, and or in person. We also provide education, both formally and informally. We facilitate linkages to external stakeholders and partners, as well as provide coaching and mentorship for the healthcare team. We can assist in helping implement tools and assessments, as well as support the team in having difficult and serious illness conversations, both within the team, as well as those that they support and care for. Our role as PPSMCs is to build capacity amongst healthcare team related to palliative pain and symptom management. Essentially, our job is to teach ourselves out of a job. So many PPSMCs can also help with the implementation of the myriad of tools and assessments that are available in the best practice guideline. So the palliative approach in the last 12 months of life has a myriad of tools and assessments at the end. So it's a wonderful resource, and which includes things like differentiating the Ontario Palliative Care Network palliative care competencies for generalist and specialist level healthcare providers, how to implement and use the palliative performance scale, so the PPS that we've been talking about, accessing and utilizing resources related to MAID or palliative pain or symptom management. Many PPSMCs also provide education and facilitation. Specifically in Niagara, we provide education through in-services as well as formalized education, including but not limited to the fundamentals of hospice palliative care, both the core and the enhanced, advanced palliative performance skills for PSWs who have taken the fundamentals core course, comprehensive advanced palliative care education, which is CAPC, which is for nurses, so RNs, RPNs, or nurse practitioners who have completed the fundamentals core and the enhanced course, and a variety of LEAP courses as well, so the learning essential approaches to palliative care, which can be interprofessional as well.
Excellent. Thank you. So many wonderful resources. And just to note, we will be providing their contact information later on in this presentation. So get ready to get that info. Okay, so Jan, I'd like to pass it over to you now. How do we ensure that our palliative approach to care aligns with the resident and family needs?
Well, thanks, Jen. I might be biased, but speaking as a long-term care best practice coordinator, I can confidently say that the best way a home can ensure that their palliative program aligns with resident and family needs is to conduct a gap analysis and implement the recommendations in the best practice guideline. The guideline speaks to the need for assessing cultural needs and values as being an important part of the holistic approach to care. However, some residents or families may find this type of assessment uncomfortable, so it is important to watch for verbal and nonverbal cues that the individual is not comfortable with this assessment. Once completed, the assessment findings need to be communicated to the interprofessional team and documented in care plans. I just want to highlight the fact that not all of the recommendations outlined in the best practice guideline may be appropriate to implement in a particular home or in a given situation. Each recommendation should be assessed and applied only as appropriate, and it is important to know that not all recommendations must be implemented or even implemented sequentially. For instance, it may be appropriate for a home to ensure implementation of recommendation 3.1 as a priority before recommendation 2.1, for instance. To implement this guideline, know that you don't have to do all the recommendations at once. Start small and build upon the great work you've already done. Thanks, Jen.
Thanks so much, Jan. So Judy, I'd love to hear from you. As a healthcare provider, how do we deliver a more culturally friendly approach to palliative care?
Good afternoon, everyone, and thank you, Jen. During my fellowship study on advancing patient and family-centered care at end of life for the Indigenous patients and their families, just spending time with the elders, the Indigenous elders in Northern Ontario in my area, as well as spending time with Kathy Loon, the Indigenous Resource Manager at the Manuwen Center in Sioux Lookout. And the big thing is what I learned from my study, and it changed my approach to care at the bedside, is it really is a time to stop and to listen and to learn. And the quote that I received from Kathy Loon was, how can you serve people you don't understand? So it just basically took me to, caused me to have a springboard into learning about the Indigenous people that we serve at Nipigon District Memorial Hospital, and just spending time in learning about their culture and learning about their traditions, and also just being respectful of the fact that perhaps I may not understand how others practice their traditions or cultures, but it's very important to be open to that. So therefore, it's very important that you have an individualized approach. It's very important to ask the questions of the resident as well as the family. What is important for them? How do they want their journey to play out in your facility in regards to being culturally sensitive? And the other very important thing is creating that safe space for sharing, and just being open to offering the supports from affiliated faith leaders or Indigenous healers. I'll talk a little bit more about what questions to ask specifically to basically open the conversation and to have that lovely space where your resident and their families can feel welcomed and that they can feel respected in that space. So I'll talk a little bit about more of that later. Thank you.
Thank you so much, Judy. So our panelists have done an excellent job of highlighting the importance of having the right discussions at the right time. So after the nurses explained the palliative care approach, Bob and his family seemed to understand and be receptive to this approach to care. John and Susie also mentioned that they've already paid for funeral arrangements for their father in the family plot. At this time, Bob and his children decide and state that they'd like for him to still go to hospital if he has another exacerbation, but understand that in the future this may change and the team will be supportive of his wishes, values, and beliefs. So this one would be an appropriate time to reach out to your local palliative pain and symptom management consultants if you're looking for support on facilitating this type of essential conversation. So 3 months later, Bob experiences an exacerbation. Bob is starting to become more confused. He's calling out for his cat and wife more. He's trying to get up without his walker and falling. He's now experiencing shortness of breath at rest and increased pitting edema bilaterally in lower extremities, which is contributing to his falls. The care team has tried to apply his oxygen via nasal cannula, but Bob keeps tripping over the cord and pulling it off. They've also given him routine Lasix, inhalers, and PRN medications with little effect. At this point, the team is concerned about these acute changes, and since they feel Bob currently lacks the capacity to make the decision, they call Susie, Bob's POA for personal care, to confirm wishes. Together, they decide to send Bob to hospital as he is in crisis. It is appropriate to send him as it aligns with his goals of care and wishes at this time. Bob is treated at the hospital for pneumonia and is now on antibiotics and routine medications for a shortness of breath, which includes inhalers, Lasix, and a low dose of hydromorphone. The hydromorphone order states it can be used for both pain and dyspnea. Bob has been discharged back to the long-term care home and is mentally capable again with periods of confusion. Bob states upon arrival back to long-term care home that he is so happy to be back and does not want to go back there, referring to the hospital. So Mahogany, at the time of crisis, Bob was not able to articulate his wishes. However, we see that his capacity fluctuates, and upon return from hospital, he's made it clear that he no longer wishes to be transferred. How could a PPSMC help support the team with his changing needs and abilities? And perhaps you could briefly explain capacity and what that means in decision-making progressing to end of life?
Absolutely. Thank you so much, Jen. So there's a lot going on in this part of the case, as we know commonly does. So let's talk a little bit about capacity. So capacity can be tricky and fluid. Even though Bob has dementia, it does not necessarily mean he is incapable or does not have capacity. Capacity needs to be determined each time in real time by the person who is proposing the intervention or treatment. This is done by assessing if the person understands and appreciates what is or is not being offered. Also, do not forget to clearly document your conversation and the capacity assessed in the moment in his chart. Just a gentle reminder that advanced care planning is not the same thing as healthcare consent. So as Jen, you stated before, reflecting back on this case with Bob, he does not have capacity at the time when he is in crisis of this case, as he does not understand and appreciate what is happening. This is why it was appropriate to turn to a substitute decision maker, Susie, who has been identified as the power of attorney for personal care. So she has a document, and remembering that power of attorney for personal care is a document. She clearly aligns his care decisions with his previous stated wishes to date. When he comes home and his exacerbation is resolved, he regains his capacity and is able to clearly articulate his change in wishes to not return to hospital for care, and he would like to remain at the long-term care home. This needs to be fully explored with the interprofessional team to ensure that they are understanding correctly the change in his goals of care. PPSMCs often consult on both pharmacological and non-pharmacological interventions and treatments related to palliative pain and symptom management for life-limiting progressive illnesses. And we can also help with essential conversations just as these and aid in navigating the legislative requirements like those outlined in the Healthcare Consent Act, the Substitute Decisions Act, and even the new changes to the Long-Term Care Act, which I noticed somebody in the chat had already alluded to a little bit. So we will talk about that, and thank you for your question.
Wonderful. Thank you so much. It's so helpful to know that there's supports out there for long-term care homes to help navigate these conversations. Okay, so back to the homes on the call. Another question for you guys. So who currently has discussions with residents and families about values, beliefs, expectations, and preferences? How are those conversations structured? What do they look like? And where and how are you documenting them? So again, feel free if you want to just unmute yourself and jump right in, or if you want to type in the chat box, go right ahead.
Jennifer says multidisciplinary team at 6-week or annual care conferences, and it's documented in the notes for the care conference. As a social worker, those are conversations that I often have upon admission. The person responsible for the admission, so the family service staff or social worker, and I apologize, the chat is flipping as you type. Every part of the care team to use information in the care plan updated quarterly for each resident. We have one palliative care conference last week, and we document it in progress notes and communicate to staff via phone call or in person. Multidisciplinary team during care conferences, RN or DOC as need arises. The doctor usually starts the communication during care conferences. RNs would also start communication with families when residents decline. It's part of our goals of care document. Admission coordinator discusses advanced care planning and wishes. In addition to the above, a brief discussion at the admission as well. We do goals of assessment yearly and on needed basis. Expectations are discussed in details with goals. I do this as part of the admission. It is also reviewed at care conference. Mostly the nurses or doctors talk to families at time of change, charted in progress notes, and I think that summarizes most of the comments.
Excellent. Thank you so much. A wide variety of options out there. So since Bob's last readmission from hospital 3 months ago, his code status has changed to DNR, and he does not want to return to hospital as he wants to die here in his room in the long-term care home. Bob has now declined in status, only taking sips of fluid and a couple tablespoons of food daily. He's in his recliner all day and night as it's easier for him to breathe. He's fully dependent on staff for all of his care needs. He's increasingly confused and tired. His PPS is 20%. Bob has identified that his religious preference prior had been non-practicing, but had always identified as Catholic. He said now, when he is in his final stages, he would like to have the sacrament of the sick. The priest has been contacted and is going to come tomorrow. Bob is now actively dying. To align with his wishes, Susie and John have both been coming in daily to sit at his bedside and talk with their dad. Susie brings Bob's cat, Jim, to come see him about once a week. So Jan, perhaps you could review how the guideline can continue to assist homes as they transition from palliative care to end-of-life care.
Yes, thank you, Jen. I'd be happy to. So these particular recommendations highlight the importance of making space for the residents' needs and wishes, as well as those of the family and loved ones during palliative and end-of-life care. This is all part of providing a person and family-centered approach to care, and it is also a requirement of the Fixing Long-Term Care Act. So becoming familiar with and implementing this guideline will not only allow you to enhance your palliative and end-of-life program within your home, provide better care to your residents and their loved ones, but also to help you address compliance issues. Also, it is important to ensure that you are following your organization's policy around documentation and ensuring that the residents' wishes are properly documented and communicated to all staff. I just want to highlight here, I noticed in the chat, after Sue had summarized all the comments in the chat, which was a fantastic summary, an individual named Allison mentioned the fact that documentation has to be updated as the residents' wishes change. So, and as the condition changes. So really, really super important. Thank you, Allison, for that comment. It is so, so important. And I'm glad you mentioned it. And again, just so important to make sure you're following your policies, your policy around documentation and ensuring the residents' wishes are current and documented as the resident's condition changes and as their wishes change, because they may change as the resident progresses through the illness. Also, just a reminder to everyone on the call today that a copy of the gap analysis, as well as the best practice guideline, have been sent to all participants today before the call, and I encourage you all to review them if you haven't done so already. If you would like assistance with the implementation of this guideline, I encourage homes to reach out to their best practices coordinator who can assist you to conduct a gap analysis on your current program and implement the best practice guideline, which again is based on evidence-based best practices. One great example of putting this recommendation into action might look like documentation on a care plan, which captures the residents' wishes for spiritual and religious care, which for some Indigenous individuals might include smudging. Smudging is a tradition common to many First Nations, which involves the burning of one or more medicines gathered from the earth. There are so many different beliefs, cultures, religions, and customs. It is impossible to capture them all in one session, but the point we want to convey is that each individual is different, and we need to ensure we are understanding what their wishes and traditions are so we can ensure we honor them. This is how we provide the best possible palliative and end-of-life care to our residents. And again, I think it's so important to recognize that just because, as with this example that I just gave you about smudging, just because an individual identifies as Indigenous or from a First Nations community does not necessarily mean they would like to have smudging done or that they want to participate in that tradition, but they may want to. So just so important to have the conversation and document your assessment so that all members of the interprofessional health team are aware of what the residents' wishes and advanced care planning wishes are. Thank you, Jen.
Thank you. So Judy, how do we discuss values, beliefs, and expectations for end-of-life care? And can you speak to after-death care as well?
Yes. Thank you very much for asking the question, Jen. Once again, it's how do we create that space? You're at the bedside and you're thinking to yourself, okay, so I want to open this up. And the big thing is that I learned from the elders, spending time with the elders, is be respectful of the moment that you are in with that person. Be respectful of the traditions, the family, the patient, the resident, the community members, as well as to the spirit world. Even though you may not understand these traditions or beliefs or values, it's very important to put your expectations aside, perhaps your biases, that type of thing. We need to be respectful. The other big thing is do not make assumptions. This is what I learned spending time with the elders. Do not assume a person is traditional because they're Aboriginal. It is important to ask all patients, all residents, if they would be interested in following through with their cultural traditions or cultural practices. So also to remember that for Indigenous, in regards to Indigenous persons in particular, it's very important that they may be Roman Catholic, they may be Christian or agnostic or atheist. Therefore, it is important to ask the question, what is meaningful to you in your last days? The big thing is the respect, not making assumptions, but also kindness. When we are the deliverers of healthcare and that we are at the bedside, it is very important to express kindness and compassion. And I think as care providers, it comes natural to us. But I just wanted to say, when you are at the bedside and you don't know what to say or do, sometimes it's really in the question in itself that provides the comfort to the person who's receiving the question. For example, what can I do to make this journey meaningful in your last days? How can I help? Again, it's creating that space, even if you're not a social worker or you're not a chaplain or you're not the doctor, you're at the bedside, and it's just something that you can do. It's very easy to just ask that question. So again, let's say the resident and the family, they share with you their cultural practices, and they state, this is what I'd like to see happen during my last days and my last day journey. And they will let you know who they want at the bedside, if they want a healer or an elder, or if they want a priest or a minister, or perhaps if the patient is Muslim or Hindu or what have you, and they'll let you know. And so the next thing to ask is, how can you facilitate that? Like, how can you, who would you like me to call? Is there somebody in particular that we can invite to be at the bedside with you? And also, just remember, this is another big thing here that I've learned during my fellowship study. All people must be treated with compassion, no matter who they are or where they come from. Understanding that the Indigenous people are hurting from the past. So we do have a history in our country that we need to spend some time and learn about. You want to learn about the person that you are treating and that you are helping in these last days. It's important to understand who they are. So be the example to your family, to your friends, to the neighbors, and as well as the example of kindness and compassionate care will navigate us all to healing. Thank you so much.
Thank you, Judy. So Tamara, we all know that there are ongoing needs for those left behind. Can you touch on grief and supports available for family members and co-residents after a resident passes?
Absolutely. Thank you, Jennifer. And just speaking from our long-term care experience here at our home. So it's so important that the interdisciplinary team is all collected so that we all have a role to play in supporting Bob and his family or in these situations. You know, our housekeepers sometimes have such a strong relationship with our family and our residents, and we don't even appreciate or recognize that, and they may be such a good conduit to them. Our dietary aides, our social workers, social service workers, pastoral care teams. So we all have a role to play in supporting Bob and the family to make sure, as Judy said, you know, we're conscious of what their wishes are and what their directions are, and we're wrapping our things to support them. And if we don't have that in our home, that we're reaching out into the community to those contact people, whether it's from a religious center, a church, or a cultural center, to come in and visit and support, and making sure that we're doing things in alignment with their wishes. But when somebody like Bob passes away and our team has been very wrapped in their care, we have to remember our frontline staff and the needs that they're going through, just the same as Bob and his family, so that our staff have an opportunity to grieve and vent as well, and that we're making sure that we're huddling with the staff, and we're having that discussion after somebody like Bob passes, and we've built those relationships, because we all go through our grieving in a different way, and we all have different relationships with you know, the family and the resident. And there's also that baggage. So what is our personal experience? What's the journey that we've had in our lives? You know, we may have lost somebody in our own family recently, or somebody's palliative in our own family. And so, you know, sometimes our reaction to those situations might be a little bit heightened. So how can we wrap and support them? And it's very difficult in our environment when we're so busy and we have so many other residents to look after, that, you know, sometimes it's hard to connect with the staff and hard to pull them for a huddle. So we have to make sure that somebody is seeking out the opportunity to talk to them, to talk to that staff member, just to pull them aside for a couple of minutes. How are you doing? You know, what support do you need? Do you want to talk about this? People need the opportunity to vent. But as with the staff, so do our residents. Bob may have had a roommate. He may have had a table mate that he became very close to, other residents on the floor. And as we've seen, as we've gone through COVID, we've had a number of losses in our home, and our residents grieve and mourn, and they're very fearful for themselves as well. So they experience a loss just the same as everybody else. And we have to be respectful that we're supporting them and their grief. You know, when we have an honor guard, when we have our residents leave our facility through honor guard or with a quilt or a ceremony, something to respect and pay dignity to that person, the residents are very observant and they watch for that. They want to know that they're going to get that same level of respect as well. And they want an opportunity to say goodbye to the resident and have those last words with the family. So I think it's so important that we don't forget anybody in the picture, in the scenario, the family, the residents, the co-residents, and our teams, and make sure that we connect, whether it's EAP, and you know, EAP is a wonderful resource, but it's something a staff member has to call and connect to. We need to make sure we're doing that connection with them. How can I help you? How can I support you? And that we're having these difficult conversations. And sometimes they're hard to start and initiate, and you have to be comfortable to start those conversations and have those words. And sometimes our staff need the support of management on the floor. There may be an after hours routine. I certainly hear our pastoral team, our spiritual team is a great resource to us. And I think that you can't exhaust those resources enough. Thank you, Jennifer.
Thank you so much. So Jen, we've touched on the important topic of grieving for family, co-resident, and a little bit about long-term care team members. Can you maybe comment on why debriefing is so important?
Great question, Jen. Well, I think debriefing is so important because the death of an individual who has lived in a long-term care home not only affects the deceased person's friends and family, it often has a profound effect, on our staff. And it is very important to debrief staff after the loss of a resident to identify those that may be struggling as a result of the loss. Our long-term care staff are our greatest resource, and ensuring they are supported is crucial in keeping our staff healthy, physically, mentally, and emotionally. A great example I have heard about related to these recommendations would be one home that held a special tea for staff after a large number of residents passed away in a home over a very short period of time during the pandemic. The home contacted their local PPSMC, who was able to lead a session with the staff during the tea to allow them to voice their grief and pain and also to support one another. The PPSMC was also able to provide information to those staff who wanted or needed additional support, and also management in the home reminded staff about the availability of EAP, which Judy spoke to earlier, and other supports available to them via their health benefits plan. For example, therapy or counseling may be necessary. Facilitating this kind of debrief is crucial in supporting our staff through these difficult situations. Mahogany, as a PPSMC, how can you assist long-term care homes with this?
Thanks so much, Jan. And I think you touched on a lot of the ways that we can support as PPSMCs. As I've mentioned, we each have kind of a different interpretation of how the role comes down, but ultimately we're here to support the team, build capacity, and we really want to make sure that they're flourishing and thriving. So to echo Jan and Tamara's previous comment, the need for interprofessional collaboration and supports for loss, grief, and bereavement is another common offering that PPSMCs can support and facilitate as part of the interdisciplinary team. We can attend shift huddles. We can also run or support both formal or informal debriefings. We can also help with connecting to external services and supports about grief and bereavement within our respective communities. It's really important to remember and create space for your grief too. Many PPSMCs can and have also run in services like those to discuss and differentiate the difference between self-care and self-soothing. It's not all bubble baths and face masks, which are examples of self-soothing strategies. Self-care is often the harder, longer-term changes in lifestyle, like setting boundaries or meal planning, budgeting, or learning to ask for more help and support if you're struggling. We can also assist with strategies on how to help navigate that. I often will also address the need for infrastructural supports at both the macro and micro levels. It shouldn't be only on the healthcare providers to build in self-care and support. Examples of supports for self-care at the macro level can look like amplifying EAP programs, enhancing benefits for therapy and counseling, and ensuring that your staff know that they're available, as well as adding and encouraging the use of mental health days or sick days. Multi-pronged approaches need to be built from both bottom up and top down. Much like the palliative care approach, grief and bereavement supports are everyone's responsibility. And I just want to say on behalf of the PPSMCs across the province, we see you and the amazing work that you have and continue to provide to support people within your care, and we humbly thank you. Please remember that we're here to help you out in whatever ways we can.
Thank you so much. And a huge thank you to all panel members today for sharing knowledge and experience with all of us. So we recognize that this case is relatively ideal in nature. However, we hope you were able to connect with this story and gain some insight on some of the resources available to you. So we're going to end our case study with a few final questions that will be discussed in a breakout room. So the two questions that we're going to be discussing are, what attributes of the palliative approach to care are you already doing in your long-term care home? And have you had any challenges? What have you learned from those? So we've randomly divided everyone up into 4 different groups, and we're going to have 10 minutes in our smaller group discussions, and then we'll bring it back to a larger group discussion and share some of our ideas and conversations. Hopefully everyone had some good discussions. Perhaps we can do a round table for each of the note takers and talk about some of the stuff that came up. So maybe Karina, do you want to start?
Sure, I can go ahead. My name is Karina. I'm a PPSMC in London, Middlesex, and Elgin, and I was just in one of our breakout rooms and just took a few notes here. So we heard from a couple of lovely people, Florentina and Jennifer, who shared their experience. So Florentina comes from transitional care unit, and oftentimes their residents or their patients will be transitioned to long-term care, and there will be some evidence of decline and having to do that communication piece. So that's really about collaboration with the multidisciplinary team, assessing and documenting those goals of care, tailoring that care plan, providing good education about palliative care to families and patients, and differentiating that palliative care approach versus that end-of-life care. And also just that focus on quality of life and just providing that reassurance to families and patients. Those are all things that were emphasized. And then the next person just talked about having those initial conversations at admission, really doing a good job of explaining the palliative approach, teaching and distinguishing, like I said, between the palliative and end-of-life care, reviewing those goals of care at all those different points, such as the 6-week and annual conferences, as well as during any time there's a healthcare change. And then just being that supportive presence for families during those transitions in the patient's care. There was this lovely program that Jennifer talked about, which was the butterfly program. So when someone's at end of life, they put a butterfly on the door as a visual cue, and they have a comfort cart that can be wheeled in to help support the family, and just trying to introduce and develop more psychosocial emotional programs in their home. And lastly, just one challenge that was brought up at the end was just that even when you do have those good conversations about goals of care, sometimes families may have a bit of a panic when there's an acute change in somebody's status, and that can just be a bit challenging in the moment. And it's just supporting that family and reinforcing that education and working through it. So that's what we had.
Great, thank you. I think we have time for one more. Mahogany, do you want to do a quick review of your group?
Sure, I'll try. I'll go real quick, like post haste. So the palliative care approach, it sounds like many of the homes are doing such an amazing job. I just wanted to emphasize it's like riding a bike, right? Like it's like training somebody how to ride a bike. You're already doing it. But many of them are doing honor guards. Many have the palliative care or end of life care teams, which they're building up the capacity. They're champions within their homes. I've heard some innovative approaches as well. So making sure that they have SPA long-term care project, POET project is another one that's sometimes out there, or CLRI, memorial services, memorial Christmas tree. I really like that one. Having resident involvement. There is a question about getting resident involvement in the palliative care approaches and the teams. A book where staff and families sign, and bedside prayers. The biggest challenges, there are two big challenges that kind of came out overwhelming. So pre-COVID, many places thought that they were doing it really well. They felt like they had a good handle on palliative care. And COVID threw a monkey wrench into everything. It kind of changed it, and it definitely did. And then the public health recommendations, so IPAC stuff like wearing a mask and things like that, have posed some really big barriers, I think, for the long-term care homes, even like the bagging of bodies, right? And cleaning the bags. Those have been really big challenges that a lot of the long-term care homes are facing. So we just talked about some possible, strategies there.
Excellent. Well, thank you so much. And huge thank you to the PPSMC team and Tamara for assisting in those breakout rooms. And thank you for everyone's participation. Brittany, I will pass it over to you.
Thanks, Jen. And thanks everyone for the very valuable conversation. I think this case study really has been an amazing representation of palliative approaches to care. How did it make you feel at the end of the case knowing that Bob's wishes were met? Isn't it an amazing feeling knowing that you were able to play such a positive role in a person's end of life journey? Long-term care staff like yourselves have the ability to impact the quality of life for residents that live in your long-term care homes. Changing the approach to care to reflect a palliative approach means that every individual living in your long-term care home has the opportunity to experience their very best days every day, including the best possible end-of-life experience. When staff adjust the way they interact with residents that they care for, they develop stronger, more meaningful therapeutic relationships. This allows staff to conduct more wholesome resident and family-centered care conferences. It changes the way they assess the residents and their families and how they understand the residents' wishes. That means that we're able to deliver the very best care in the ways that are actually meaningful for that resident. So how can you enhance the amazing work that you're clearly already doing? As we've already said many times throughout this presentation, we highly encourage you to contact your best practice coordinator so that you complete a gap analysis on your palliative care program. What does that mean? It means looking at what your program already is doing and how we can enhance or improve certain aspects of that program. We hope that you'll invite us to your interdisciplinary staff meetings so that we can help identify these gaps together as a team with the people that already know what's going on in the home, and we can outline the recommendations through our gap analysis. This will help us formulate action plans to assist with the development of implementation plans, which will help set priorities, and then we can assist with education and delivering these priorities to your team. It's important to share the home's priorities and action plans with the whole team so that you can move your recommendations from the best practice guideline into action. A palliative approach to care is really outlined in the Fixing Long-Term Care Act, and best practices can assist you to deliver evidence-based informed care to the residents living within your home. Your best practice coordinator can help support and assist you and your team with aligning your program with the new regulations. Please keep in mind that we have many best practice guidelines that are complementary to one another. You may want to combine your efforts and review and implement more than one of the guidelines within your mandatory programs. After today's session, you might be thinking about the assessment and management of pain, a person and family-centered approach to care, and end-of-life care during the last days and hours. I want to take a moment to thank the PPSMCs that helped with today's presentation development. To find and connect with your local PPSMCs to see how they can support you and your team, please check out their website at www.pccsnetwork.ca. Questions or would like more information on Judy's research and ACPF work, she welcomes you to reach out either via email or phone. And if you enjoyed today's webinar, it will be recorded and posted for viewing on our events page. Also, feel free to bookmark this page on your computer's homepage. This way you don't miss out on future educational opportunities provided by the RNAO. Your feedback is important to us, so we're going to ask you to please complete a poll. Okay, well, I don't see any questions in the chat box, and I'm not seeing anyone raise their hands, so I just want to thank everyone for their attendance today and participation. We really enjoyed hosting today's session, and if you have any questions, you can always reach out to us at a later date via our website. Thanks so much, everybody.